Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I would like to welcome our audience to today's event. I'm Dr. Brian Kaufman, the co-founder, executive vice president, and chief medical officer of CLL Society. And we are joined by Dr. Jacob Soumerai, who's an assistant professor at Harvard Medical School and a clinical investigator in lymphoma at Mass General Cancer Center, and Dr. Andres Chang, who's an instructor at the Winship Cancer Institute of Emory University. We will be answering audience questions at the end of the event, so please take advantage of this opportunity and ask your questions in the Q&A box. Before we begin, there are a few important disclaimers I want to share. The information provided today is for educational purposes only and should not be considered medical advice. For any personal health or treatment questions, please consult your healthcare team. Please note that while CLL Society may have its own opinions and policies, our speakers may offer differing viewpoints, especially regarding the management of CLL and its complications. Now it's my pleasure to introduce and welcome Dr. Jake Soumerai.
So I'm Jake Soumerai, and I'm a CLL doctor and clinical investigator at the Mass General Cancer Center. And many thanks to the CLL Society for inviting me to participate in this really important program. Today, I'm going to present on CLL and the immune system. And we're going to cover the following three learning objectives. First, how is the immune system affected by CLL? Second, how do CLL therapies impact immunity? And finally, what does this ultimately mean for patients, right? So we have long known that the immune system is abnormal in people living with CLL. Many years ago, before blood work to measure white blood cells was routinely performed, many folks with CLL were actually diagnosed because they presented with recurrent infections, and they went looking for underlying causes and lo and behold found an elevated white blood cell count. These types of infections could be bacterial, viral, or fungal infections, including types of infections that only occur when people have weakened immune systems, suggesting that this wasn't something that was, maybe just a slight increase or uptick in the number of infections, but really there was more to it. There were some real abnormalities in the immune systems themselves. Later on, we learned that greater CLL disease burden, this means, how high is the white count? How large are the lymph nodes, right? Greater CLL disease burden seemed to be associated with higher infection risk, suggesting that the disease itself contributed to this risk. So our immune system is actually comprised of two systems, right? There's the more primitive and fast-acting, the first responder, innate immune system, and the more specialized and longer-acting adaptive immune system. These must be highly coordinated, and they work together to protect against infections and actually also cancers. Their powers must be kept in check, however, as excess immunity can actually cause harm. When the immune system is off balance, it can attack our own organs and cells. This is called autoimmunity. And there's actually a whole field of medicine devoted to the group of diseases, these autoimmune diseases, where the immune system is attacked self. Autoimmune diseases. The innate immune system is the most primitive part of our immune system and includes numerous immune cells that are designed to prevent and kill infections and cancers. These are our first responders, right? They have sensors that alert them to a wide range of invaders, from infections to chemicals to cancers, things that are not supposed to be in our bodies. They are capable of clearing the intruders themselves, but they actually also recruit other parts of our immune system to mount a more coordinated attack. There are many types of first responder immune cells, which often don't function properly in folks with CLL, which we know can contribute to infection risk. The adaptive immune system, meanwhile, is far more specialized, right? And this includes an army of B cells and T cells, which are each designed to recognize very specific invaders. So unlike the innate immune system, where they have sensors that say there's something that's not supposed to be here, these are all primed for very specific intruders. Now, B cells make antibodies to clear infections, right? The antibodies are really critical to this process. T cells themselves kill infections and prevent cancers. Now, true to its name, this part of the immune system adapts to what it experiences, right? And it produces memory of past invaders, such that it can be more efficient at clearing infections when they recur down the line, right? So if you've had an infection before and it took you some time to clear it, you learn how to attack it. You sort of learn this infection. You're ready for the next time around, and you're better at clearing it the second time that you encounter that bug. Now, in people with CLL, this part of the immune system is also abnormal, which contributes as well to infection risk. So let's focus a little bit on antibodies, and specifically IgG antibodies. B cells make antibodies such as IgG antibodies that can be measured in your blood. You may know this as your IgG level, something that your doctors may have checked once when you were diagnosed or may follow. This is something that there's some variability in sort of how this is tracked. These are very important for clearing infections, these IgG antibodies. In particular, bacterial infections in the sinuses, the respiratory system, and the skin, but also other types of infections as well as viruses and others. IgG antibodies are low in about 2/3 of people living with CLL. Now, fortunately, only some of these patients will develop recurrent infections as a result of this. When people with low IgG levels have severe or recurrent infections, we can increase the antibody levels with infusions or injections. This is often called IVIG, or intravenous immunoglobulin. Now, I would argue that this reactive approach, where we wait for infections and then only intervene when they develop, leaves much to be desired, right? I think we need a more proactive approach. But to accomplish this, we need to learn more about infection risk, right? We need to better understand why some patients have high infection risk despite relatively normal antibody levels, which can happen, while others can have extremely low antibody levels, yet never have infections, right? So I think that there's really room for improvement and growth in this field to better care for our patients in the future. Now, CLL treatments also impact the immune system. Now, chemotherapy really is no longer used in CLL here, but many current patients were previously treated with chemotherapies. And many of these chemotherapies can have long-lasting effects on the immune system. If you've received fludarabine or bendamustine even years ago, we can still see effects of the chemotherapy on the bone marrow or other types of immune cells that can influence infection risk. Antibody therapy, such as the CD20 antibodies, which target B cells, for example, obinutuzumab and rituximab, directly reduce B cells because that's their target. And this can lead to lowering of antibody levels, which, as we just discussed, can lead to certain types of infections. Now, modern targeted therapies like BTK inhibitors, such as acalabrutinib and zanubrutinib, the BCL2 inhibitor, venetoclax, and others, are much more complicated, right? So these, in general, don't suppress the immune system as deeply as chemotherapies or as broadly. They tend to interact with the immune system in much more specific ways, but they interfere with many different types of immune cells. And we know that these drugs lead to increased infections in some ways, although it's possible that in other ways they might actually correct some abnormalities in the immune system. And so there's many sort of complicated ways in which these novel therapies actually interact with the immune system and influence the risk of infections, right? And so I would argue that with targeted therapies, it requires a much more detailed discussion based on the individual drug or medicine that you're taking. So going back to thinking about how we actually estimate infection risk to guide our patients. Most of what we know about infection risk in CLL either comes from the chemotherapy era or from the early phases of the COVID-19 pandemic, right? Now, this makes it very hard to estimate infection risk for people with CLL, maybe who are diagnosed now and only receive modern therapies in the future, right? Maybe they had all their vaccines long before their diagnosis, right? So it's very hard to know how the data that we have from many years ago, or even from a few years ago, can be applied to somebody who's diagnosed with this disease today. And like all other aspects of caring for people living with CLL, I would argue that we really should strive to estimate infection risk on an individual patient level, right? You can see 10 different people living with CLL, and you really have seen 10 different diseases, right? There are no two patients who are completely alike. And I think that if you look at infection risk for two patients can range from near normal, right, to somebody with maybe minimal disease burden, has never been treated, has been fully vaccinated, has normal antibody levels, to very high risk, say somebody who's had a lot of prior therapies, including past chemotherapy, right? And so these two patients are very different and should be approached and counseled in different ways. So how do I estimate an individualized infection risk? Well, I consider a patient's age, what comorbidities they have, what other medical problems, do they have diseases aside from the CLL that might impair their immunity or lead to some particular risk, like, for example, emphysema or COPD and pneumonia risk, something along those lines. How much CLL do they have? Do they have a very high white blood cell count, a lot of disease in the lymph nodes? What are their antibody levels? Or is their IgG level very low, as we discussed before? And what treatments have they received, either in the past or in the present? And when, right? It's because some treatments have a more durable effect, whereas others, the effect really wanes once you stop it. Finally, we can learn a lot about a patient's personal infection history, right? Just because somebody is diagnosed with CLL today doesn't mean that it started today, right? It often has been present for years. And so if we look back and ask a patient, well, how have you done with infections? And they say, well, I've had the flu and COVID and this, that, and the other, and I actually do better than the rest of my family. Well, you probably feel a little bit better about that patient than somebody who's telling you that they've had many infections and really struggles to clear them, right? As I alluded to before, the immune system is also important for preventing cancers, which, like infections, present themselves as invaders. They're not self, right? They're not supposed to be in your body. Because these immune cells are often dysfunctional, they often don't work totally normally in people with CLL, we do see higher rates of other cancers, in particular skin cancers in our patients. I encourage patients to have routine age and risk factor guided cancer screening. And it's very important that all patients with CLL see dermatologists for routine skin checks, at least annually, to prevent skin cancers. As these can otherwise become more invasive and more troublesome. And I consider, this to be really a never event, right? I mean, I think that if you continually monitor with a dermatologist, if they detect these early, often at pre-skin cancer stages, or at least at early skin cancer stages, they can really avoid serious trouble in the future. Finally, the immune system is off balanced in people living with CLL, as I've mentioned. And this can redirect the immune system against patients. This is actually called autoimmunity. In CLL, autoimmunity most often results in decreased red blood cells or platelets. We call these complications autoimmune hemolytic anemia with red blood cells, or immune thrombocytopenia, or ITP, with the platelets. Other much less common autoimmune complications can also occur. We usually treat these conditions with steroids, things like prednisone or dexamethasone, although sometimes only treating the underlying CLL is effective. And so it really depends on what specific complication it is, and oftentimes seeing how folks do with steroids. Are we able to control it quickly, or do we need to add something to really control the CLL itself, which may be the motor underlying it? In summary, the immune system can be dysregulated or imbalanced in people with CLL, and this may lead to infections, other cancers, and autoimmune complications. It is critically important that our patients take infections seriously. This means notifying doctors when infections occur, as early diagnosis and treatment can improve how patients do and can lead to faster recovery in the case of therapies, right? And also notifying doctors if they experience recurrent infections or severe infections, as your doctors may be able to reduce infections with preventive measures. For example, if your IgG levels are low, this is something that we can fix and we can actually reduce infection risk. And finally, routine cancer screening should be performed. This is really important. And in particular, dermatology visits to conduct full skin exams to prevent skin cancers. I'd like to thank the CLL Society and all of you again for this opportunity to participate in today's program. And I'd like to welcome Dr. Andreas Chang now to continue with his portion of the presentation.
Good afternoon, everyone. Thank you for having me today. I'm gonna talk about how to prevent infections and what we know about immune reconstitution in CLL. And so the learning objectives for this talk is to provide you with an overview of the strategies to minimize the frequency and severity of infections, and also to discuss the potential strategies that might be available in order to reconstitute the immune system in patients with CLL. And so let's start with talking about infection prevention. Okay, and like Benjamin Franklin once said, an ounce of prevention is worth a pound of cure, and that is definitely true when it comes to infections, especially in patients with CLL. I want to stress the fact that things like what I call common sense measures, okay, the measures that we instituted during the pandemic, including avoiding sick contacts, performing proper hand hygiene, wearing masks, but also improving air quality around our environments, having good public health measures and community surveillance, and those kinds of things actually do work. And I want to use this graph here on the right as an example where you see the different shades of blue. This is a different strains of influenza viruses. And you see the higher the peak is, the higher the incidence or the prevalence of it, that particular virus is in the city of Seattle. And you can see on the over here, over time, that starting in 2019, in the winter times, we see a peak that corresponds to what we normally call the flu season. And then over the summer, the amount of influenza infections is lower. And then over the next flu season, we see another peak. But I want to point out to what happened in April of 2020, right? This is at the beginning of the pandemic when we all had to lock down and people stopped eating out, people started wearing masks and all these things. And look at what happened with, again, influenza infections. And we see that those dramatically went down and stayed down. And we really, in 2021, really didn't have any much of a flu season. And even in 2022, there isn't much of a flu season either. And this just highlights how instituting some of these measures can potentially help at preventing infections. And this is true also if you look at influenza infections worldwide. Here, different colors depict, again, different viruses. And now remember, this is worldwide data. And so there's also some influenza infections in the Southern Hemisphere during what for us is in the summer. But you see a huge peak over here in the 2020 flu season. And then come April, we have a dramatic reduction, and there's really not much activity in 2021. And it's not until 2022 where some countries really started opening back up, where we see infection rates from influenza going back up again. These common sense measures are in fact so effective that throughout this period, we were effectively able to eradicate one of the 4 influenza strains that are depicted here. So what about vaccines? Well, vaccines are not designed necessarily to prevent infections, but rather to reduce the risk of severe infections and hospitalizations. We know that that's true for many most people in the general population, but we also know that patients with CLL mount suboptimal antibody responses to vaccines. What that means is that the antibody titers, the amount of antibodies that are produced after vaccination, might be lower than in the general population. And so there are different ways in which we've tried to mitigate this deficit. Most commonly is through additional booster vaccines, and in some cases, these might help. But also to try to better understand what happens to the other compartments of the immune system, such as what happens to T cells after vaccination, and that sort of thing. In my practice, I still tell people and I still advise people that they should get vaccinated because some response is better than no response, right? And so I still commonly recommend patients to receive their annual influenza vaccine, COVID vaccines, RSV, if they haven't had the pneumococcal vaccines, their shingles vaccines, and so forth. And also to stress the importance of vaccinating close contacts, because if you vaccinate close contacts, then the risk of infection to the patient is reduced. I do want to point out that we should avoid using live vaccines during periods of significant immunosuppression. This significant immunosuppression happens usually around or soon after the times of certain therapies, but those should be discussed in more detail with the patient's provider. Now, there is another strategy that we have employed historically to try to reduce the incidence and the severity of infection, and that is to administer some sort of a prophylactic medication or preventive medication ahead of time in order to reduce those potential complications. One of the best examples and probably better known examples is this medication called AZD7442, which was branded as Evusheld during the height of the pandemic. This was a cocktail of monoclonal antibodies that aim to reduce the risk of severe infection in immunocompromised patients or high-risk patients. But as you probably will know already, this medication is no longer effective, nor is it available for our patients anymore. That said, there are new antibodies that are coming up. Pemivibart and sipavibart are two of these such monoclonal antibodies. One of them, the first one, has received emergency use authorization, but none of these medications have had their publications out yet, and so there's still a lot to be known about the true effectiveness of these medicines. Now, even before the pandemic, we in the CLL community have used this medication called IVIG, or which is essentially a mixture of polyclonal antibodies, in order to decrease or reduce the risk of recurrent and severe infection. And in fact, there's on the figure on the right, this is a publication by Dr. Soumerai earlier this year, where he looked at a cohort of CLL patients and lymphoma patients and determined that patients who actually get this IVIG treatment have decreased rates of infection and decreased rates of the use of antimicrobial medication. There is, in fact, currently undergoing a clinical trial called the PROCEED trial, which is trying to look at this question of effectiveness of this IVIG prophylaxis in a prospective manner. And hopefully that will give us even better data on how to best use this medication for in order to protect our patient population. And then depending on the circumstances, doctors might be prescribing medications such as acyclovir or valacyclovir for to prevent herpes reactivation, and entecavir, which is used to prevent hepatitis B reactivation when we use anti-CD20 monoclonal antibodies. In some cases, we will use trimethoprim sulfamethoxazole or brand name Bactrim in order to prevent certain bacterial infections. antifungals, and so forth. And all those things might need to be discussed in more detail depending on each person's particular scenario and treatment. Now, what happens when somebody actually has an infection? How do we manage that for our patients? Well, one of the key things that we need to keep in mind is that prompt initiation of therapy is key to a good outcome. I highly encourage our patients to seek care early when the signs of infections first manifest, and that is because it's a lot easier to treat patients early in the infectious course, and sometimes, in some cases, medicines only really work when we start treatment early, and that is in the case of influenza with oseltamivir or brand name Tamiflu, as well as with COVID, which we have several different medications, most notably the combination of nirmatrelvir and ritonavir, or brand name Paxlovid, which is probably the preferred agent for in most cases. And then, of course, for bacterial infections, we have antibiotics, and for fungal infections, we have antifungals. But again, I cannot stress enough the importance of early initiation of therapy. So in the last couple of minutes, I want to talk about a little bit of data of what we know about immunodeficiency in CLL and how we are able to revert this. And so there are now a few publications that have come out that have shown that patients who are receiving BTK inhibitors as their treatment for CLL actually might have better T cell function. And so that is something that some people have kind of tried to develop this further into a way to reverse the immunodeficiency. But I do want to point out also that BTK inhibitors also have been shown to reduce antibody response, which is the B cell side of things. And so whether one has a net benefit from an improved T cell function or not because of the reduced antibody responses remains to be seen. PI3 kinase inhibitors, which are medications that we used to use a few years back for CLL, might also improve T cell functions, but the reason why these medications are no longer used is actually because there is a higher risk of opportunistic infections. And so its true role in terms of how much the immune system is strengthened by these medications is really up in the air. And then there's some early data suggesting that if we treat CLL and if we can get them into undetectable measurable residual disease status, that's in some cases, the immune system actually does respond better, and there's some reversal on some of these markers associated with a defective immune system. All in all, though, I would say that this is an area that a lot more studies are needed so that we can clarify the mechanisms of immunodeficiency in CLL, and so that we can also develop better mechanisms and better methods in which we can reverse this immunodeficiency. And so to conclude, I want to stress again that prevention is better than treatment. And so some of these common sense measures, I still educate my patients on them, trying to either wear a mask or avoid very crowded places, avoid sick contacts, vaccinate patients, vaccinate their close contacts. In some cases, antimicrobial prophylaxis might be prescribed by the patient's provider. Pre-exposure prophylaxis is coming for at least for COVID, hopefully for some other diseases as well. And then IVIG, which is which I will say is pre-exposure prophylaxis for more than just COVID or one disease, might also be beneficial for certain patients. All these measures should be discussed also in more detail with their particular provider. And then early treatment is important for people who have confirmed infections. And then more studies are needed to understand the mechanisms of immunosuppression and how to reverse this process. And so with that, I want to thank you for your attention, and we will turn into our question and answer section.
I hope everybody enjoyed these presentations. I sure learned a lot, and it's certainly a hot topic, and I'm looking at the questions just keep pouring in. So very, very exciting. I want to thank Drs. Chang and Soumerai for these very informative talks on CLL. Please, we'll begin answering your questions, but we'll try to get to as many as possible. If we're not able to get to your questions for any reasons, please email them to Ask the Expert email after this event, and we will share that email at the closing. So there are so many great questions, and I wanted to start with one that has different kinds of themes, but I'll throw this to both of you. We understand that CLL patients are immunocompromised. Is there anything that they can be doing? Are they taking multivites? Is exercising going to help? There's a lot of the microbiome has got a lot of attention recently. Is there anything in terms of probiotics? We've heard maybe CLL patients shouldn't take probiotics, because it could be dangerous for them. Is it safe for them to take it? Does it make any difference? Is there anything that they can do without going to their doctor? And then we'll talk about what you can do as physicians to help improve immunity at different phases. Andres, do you want to start?
Sure. Thank you very much, Dr. Kaufman. So I think, in general, there are no strong data that have been published that either shows a conclusive benefit or a conclusive harm of things like probiotics or doing, certain diets, certain supplements, and so forth. What I do counsel my patients, and Dr. Soumerai kind of alluded to this too, is that if the healthier the patient is, the better their immune system is going to work. And by that, I mean, if somebody's active, somebody's eating healthy, somebody's having minimal what we call comorbidities or other kinds of diseases that are piling up, then the chances of that particular patient's having a stronger immune system and therefore a fewer number of infections kind of improves.
Jake, do you want to add anything to that?
Yeah, I couldn't agree more. I mean, I think that that involves both general, the general diet, exercise, health, all these other things that we do to keep ourselves healthy. Also, sort of routine primary care. I think that I worry sometimes that primary care is sometimes difficult to establish in this day and age, and something that I like to ensure is that my patients, although we establish a relationship that goes on, I tell all my patients they're going to our goal is that they retire me, right? That there's a long relationship, but that they really should sort of maintain a connection with their primary care docs to address any other major medical issue. For example, make sure that COPD is better controlled. Don't address anything else that might be associated with infections that might further increase the risk, sort of just beyond the CLL itself.
Both of you talked quite a lot about vaccines, and I think that they're the backbone of a lot of the prevention, but there were some questions about, here's a basic one, Dr. Chang, and then I'm going to follow up with a couple others. What is DTaP? You mentioned what is TTAP? Can you remind patients what that vaccine is and when they need that? And maybe you also mentioned live, not get live vaccines. Remind us what vaccines are live that a CLL patient should not get.
Yeah, so Tdap is a vaccine that is all based on toxins. It's against tetanus, diphtheria, and pertussis. Normally, this vaccine is recommended to be given to patients every 10 years. And so given that a lot of our patients will have CLL for over 10 years, then chances are that they will be due for one of those vaccines at some point while they have the diagnosis of CLL. In terms of live vaccines, really for adults, it's mainly there's a live attenuated varicella shingles vaccine that I usually counsel patients to stay away from, especially now that we have a shingles vaccine that is not live. And so that will be really the main one. The other vaccine that has live viruses is the measles, mumps, and rubella vaccine, but that usually is a vaccine that is given to kids.
And while we're on the vaccine question, there was something about after having a transplant, which is used less and less in CLL, you need to be revaccinated. I wonder if you could comment on the timing of that, Dr. Soumerai. And also, I'm hearing that people have CAR T, which is becoming more important. When I had my CAR T, there wasn't a lot of talk about vaccinations, but friends who've had it subsequent, I had mine, 7 years ago, very early in the CAR T story. But people now are saying, no, you've got to get revaccinated. So what's the story on that? And do we have to, do some of these treatments need that we need to be revaccinated? So is there thinking about that? If you could share that with us, starting with the transplant, which I think has the most data on that.
Yeah, thank you. It is a great question. So as you said, most of our data comes from the transplant setting. And there we're talking about a wide range of vaccines, right? And these are really repeating all of our childhood vaccines, because when you get sort of when you have either the types of chemotherapy when you have the types of chemotherapy that can really completely remove your bone marrow function such that you need to replace it, you need to retrain these immune cells to fight these childhood vaccines. And so there are a number of different schedules, and these have actually evolved over the years. But in general, if you think back to, or if you think of family members who've, as children, have had all their childhood vaccines over the first several years of their life, that's basically what we do. And over the first few years after a transplant, we do these revaccinations. Now, CAR T cells is another interesting question. So, I was heavily involved in the early CAR T cell studies that led to the approval of liso-cel, which is a type of CAR T cell therapy. Now, this is a type of treatment, right, that sort of where your own T cells are re-engineered to go after a protein or sort of a flag that we know is on CLL cells typically, such that the immune system, these T cells, can then attempt to kill off the CLL. This involves a couple of very immunosuppressive things. The first thing is that it involves fludarabine and cyclophosphamide. These are chemotherapy drugs that we used to use a lot in CLL, but we don't anymore. And these have a broad effect on many different types of immune cells, but it also involves the CAR T cells, which really bring down B cells and antibodies quite a bit. And so in the studies, we didn't revaccinate. This has never been a thing that we have really sort of done early on, but with COVID, I'd say that this has evolved a little bit. And so we did early on, and we do continue to suggest that people get revaccinated against COVID, for example, 3 months out from their CAR T cell therapy. The truth is that this is with very little data, and this is just based on sort of consensus and expert opinion rather than based on studies that show that this is really unequivocally the right thing to do.
Yeah, so a couple other questions. There's a lot of questions on vaccines, and people have had, let's talk about the COVID vaccines particularly. If people have had no response, people, you can get tested to see if you have response to the spike protein and you haven't responded to it. Are you still recommending that people get the vaccine? And do we know anything about T cell response in the absence of antibody response? Because I think you elegantly touched on these different aspects of the immune system. Dr. Chang, do you want to take that?
Sure. So like I mentioned, some response is better than no response. And so for testing for antibodies is something that we sometimes do, but it's not routine practice for all the patients. And so for most patients, I still stand by that statement. of some responses, but no response. Now, there are papers and published data showing that people who do not have an antibody response, they might still have a T cell response. Now, how effective that T cell response is and how much of a protection that confers clinically is a little bit up in the air. But I think that the fact that at least one branch of the immune system is responding to the vaccine, it probably means that it gives some benefit and some protection. And so I think that as long as one branch of the immune system responds, I would still recommend patients to get that. But this is, as you know, is a very hot area of research right now.
I'd maybe just add we did some early work looking at the immune response to COVID vaccine. It was really interesting that there were people, most people did have a T cell response, but also actually, even though there were patients where we couldn't identify antibodies using the tests that are available, say at Quest or in the clinic usually, we actually were able to identify antibodies using a more sensitive method in all patients. And so I think that I actually recommend in general, outside of a study, I recommend against using that test. I think that it causes potential harm because if you don't have a positive result, you might think you're not protected, but you might be. And on the other hand, if you have a positive result with that antibody test, it's not a license to go and lick the subway, right? I mean, it doesn't tell us that you're clearly protected against COVID. And I think that, to me, the most important thing is what happened when the vaccines came out, right? We were losing, it was devastating, the number of patients that we were losing in the clinic every week. And then the vaccines came out, and there was this just dramatic reduction in severe illness and death. And it's been a couple of years now since I've had a patient of mine pass away from COVID. And it's actually pretty uncommon now that my patients end up in the hospital with COVID. So I'm not saying this isn't a major issue and a real problem. There are patients who have real trouble with this illness, and we have to do all we can to protect it. But what this tells me is that we can't take our foot off the brakes, right? That vaccines were probably the most important thing that we did to tackle this problem in folks with CLL and SLL and other lymphomas, but focusing really here in the patients that we care for mostly with CLL and SLL. And so moving forward, it's just so critical that we protect ourselves against changes that may develop that make this more problematic again if we don't continue to vaccinate the community.
Yeah, and again, I think to underscore, we're not aiming at no infections after vaccination, right? Like, I mean, this is just like common colds and flu. People can still get infected after vaccines, but the goal is to keep patients out of the hospital, to keep patients from dying from this disease, or even having more severe illness that puts them in bed for like 3 to 5 days, right? I mean, if it's a mild disease, then I think that the vaccines are doing their job.
Let me ask a question that's tangential to this, because you both treat a lot of CLL patients, but I think it's an important question that keeps coming up. COVID is not going away. We know that. And protection is good, but it's far from perfect, and there is a risk. So how are you counseling your patients about their life? Because I know people that are still locked at home, that won't go out, that won't do anything. And then I know other people who say, forget it, this is it, I'm doing everything. And there's a lot of us in between, and I'm, on a personal level, I'm not going to big concerts. I'm very nervous about eating indoors at a restaurant. Plane flights still make me nervous. I wear an N95 mask. What are you counseling your patients about doing this? So, because there's a real psychological risk to staying locked down. So maybe I'll start with you, Dr. Soumerai, and how do you have that conversation? Because this has got to be an ongoing patient. And does it vary during the course, depending if they've just gotten a transplant? Obviously, it's different than if they're in deep remission, but talk to me about that conversation.
Yeah, thank you. I think this is so important because I think there's risk on both sides, right? I think that there's, on one hand, if somebody is particularly immunosuppressed, like let's say, let's say I'm caring for somebody who's had a lot of chemotherapy and just got CAR T cells, that's somebody I'm worried about. But and maybe their risk is more from, say, getting an infection. On the other hand, I have patients who, as you've pointed out, really don't leave the house and have disconnected from family, don't see grandchildren, like and I have patients that are depressed or who have had memory issues, right? I mean, like there's a lot of downstream effects of really being so isolated. And so I think that this is where we really need to do a better job of trying to identify who's at greatest risk and trying to sort of match our counseling to the person. But in general, I don't take a one size fits all approach. And I do this in the clinic. I talk to people about their individual risks, what makes the risks higher or lower. I tell them that there's not a rule, right? Like they're allowed to travel, they're allowed to do things, and it's about sort of risk benefit. And just as a point of example, in the clinic, we don't have a mandate for masks anymore. But if I have a patient who's wearing a mask, I wear a mask, right? Like I do it out of respect because it's important to them. And if I have a patient who's not wearing a mask, I don't wear a mask because I ask them if they want me to, actually. But I think that there's value in faces and there's value in other types of communication. So I think that counseling patients and the way that I approach patient care really comes down to a more involved discussion about this and understanding sort of the risks and benefits of sort of either extremes and finding where that person's comfort level is.
Dr. Chang, you want to add? That was great, by the way. I totally agree. And it's we say, and you mentioned this, if you know one CLL patient, you know one CLL patient, and you've got to customize everything. Dr. Chang, anything you want to add to that?
Yeah, I think Dr. Soumerai and my approach is very similar, that we highly individualize the counseling, and we spend quite a bit of time talking about this particular subject because of its importance. And many people have kind of alluded to, the world has moved on, but I'm still around and I'm still immune suppressed. So what do I do? And I think that the other thing to keep in mind is, we still know when there is a disease prevalence or an uptick in certain infections versus when things are kind of at a very low baseline. And I think that the risk of it not only depends on the individual patients, but also on the circumstance, both at the society level as well as the people around them, right? The immediate people around them and what they want to do. And so if it is, late spring, early summer, COVID cases are very, very low, that probably means that the risk is much lower to patients than when cases are really high. And so there is that aspect of it too that I counsel patients on.
I'm going to move off of vaccine soon, but there's a couple other quick questions. Yellow fever vaccine, Dr. Chang, that's a live vaccine. If you've got patients who want to go on a safari in Africa, what are you advising them?
Yeah, that's an interesting one that we normally don't give a lot of don't give this particular vaccines to a lot of patients. I think that it also kind of depends on what kind of underlying CLL status we're talking about for that particular patient, where they have treatments, where they've had infections, recurrent infections in the past. I think that that also as Dr. Soumerai mentioned, tells you a lot about what CLL in of itself is doing to that particular patient's immune system. And so there's not a straightforward answer. I think that it really depends on the patient, whether you'll be comfortable recommending such a vaccine or not.
Yeah, and I think there are no data, if I'm correct, about the live vaccines being risky. It's just we assume that they're risky. And there are case reports of them being risky and people getting disseminated disease from the attenuated or weakened vaccines. We know that. And we know that from a smallpox history and other things like that. But I don't think we have data. And I think it's something that may at some point, if there's an ethical way to reassess that, needs to be reassessed. Remind us of the protocol for RSV vaccine. Is that a one-time shot? And also that to you again, Dr. Chang, if you want. Is that a one-time shot or does it get repeated? And is that something that you're recommending for all your CLL patients?
Yeah, I do recommend it for my CLL patients. It is a new vaccine, and so the frequency of how often this will be administered is to be determined. Just like when the COVID vaccines first came out. But I think that in general, I would say that most patients will benefit from getting the RSV vaccine. Compared to not getting it. And I think that I saw one person saying, sometimes if you don't fall in the age category, you might get a pushback. But I think that if you really want the RSV vaccine, but just by virtue of having CLL, it should be approved for you to receive the RSV vaccine.
You do have to push sometimes if you're not in the age group, but you can get it. You can push for that. Okay, I'm going to move off of vaccines and move to another area, just a big, broad area. So, Jake, you discussed this. Should every CLL patient consider themselves immunocompromised to some greater or lesser extent? Like, I mean, the minute you get that diagnosis, you've had no treatment, you're feeling great. You went in for a hernia repair. The CBC showed your blood count showed that you had lymphocytes. You were shocked that you were told that you have this blood cancer that's incurable. And now you're immunocompromised too and at high risk. Talk me through that. Is everyone or I got venetoclax and obinutuzumab. It's 3 years later. They can't find a trace of CLL. I'm undetectable, measurable residual disease. I feel great. Am I still immunocompromised?
Yeah, those I think are and I'll address I think both those because I think those are both really good questions, and I'll address them maybe one then the other. Is everybody immunocompromised? I think the answer is probably not. There's probably some people who have a level of immunity that's similar to their neighbors, and who are those people? That's part of the problem is that we don't have the best test to identify that. But if I had to venture a guess, and again, this is just a hypothesis, it's probably the people that are most likely to be in that category are probably people who have the tiniest amount of disease that have never been treated, and probably without other like major comorbidities, although we could maybe separate that out from this discussion. And we know the reason that I say that is that we have some earlier evidence, right, that the amount of CLL is associated with infection risk. And so if somebody who has, one cell over the cutoff and to be called a person living with CLL as opposed to a monoclonal B-cell lymphocytosis, do they suddenly have a major immune deficit? I don't know. I think that's not known, but those folks probably are at a lower risk. What I counsel patients is that their risk is probably more than it would be if they didn't have CLL. But to what extent, we don't know. And we sort of then go into the different factors that sort of guide us. But all the data we have is on more of a population level, and it doesn't really give us such specificity that allows us to say every single patient has that immune dysfunction. The treatment effect after time-limited therapies, I think, is a really great question. We're very passionately interested in this right now, and a lot of my interest is in developing these time-limited treatments, right? So Most of my clinical trials, for example, are combinations of therapies to try to achieve deeper remissions, to try to stop therapy in more people, maybe even sooner, so that we can have more time off therapy. Because I just think in general, my patients might like me, but they don't want to see me as much, right? So I think it's better to try to be off therapy for some people, right? And so the question is, if we remove CLL from the equation with a medicine, if I get down to the point that I can no longer detect any CLL, say even like 1 in a million cells, and let's say that we're now out 3-4 years, as you just said, and we're at a point where we still maybe can't detect it, although often we can, but at a very low level often, and we've had recovery of B cells, right? Maybe even recovery of immunoglobulins or these antibodies that often go down with some of the therapies that achieve these kinds of remissions. Where are we then? What is our infection risk then? And does it return to normal? This is just a complete unknown. This is an area where I think that we need to do, we're going to get this data. We're going to get a lot more information in the coming years. I would expect that the risk is, I'm sure, lower over time, but how much lower and how close does this get to normal, I think is unknown.
Dr. Chang, you talked a lot about immune globulins and IVIG replacement. Can you just review a little bit about that, the indications for that? And could you also touch on, we can give the immune globulin as subcutaneous. Does that work as well as by giving it by intravenous? Is that something patients can do at home? Do we have data on that? And just talk talk a little bit about the, people have had low IgG, but also low IgA and IgM, and that's not replaced with the IgG that you get in the immune globulin. So if you could just walk, I know this was covered, but people had some questions on it still. Yeah.
Yeah, you touched on a lot of important questions, and I think it probably involves a whole new hour talking about this. But in general, what I would say is IVIG or immunoglobulin G replacement is, like you said, only replacing IgG, does not replace IgA or IgM, which are also immunoglobulins that are important for protection for other types of diseases. But in general, we think of the protection that is conferred for most viral infections to be IgG. IgA tends to block infections at the mucosal level, or meaning right at the site where viruses come in, and so definitely has an important role. But we don't have any sort of medication that addresses that at this point. The data that we have in terms of immunoglobulin replacement, and I show that figure from Dr. Soumerai's paper. It does seem like we have good data, at least in a retrospective manner, that it works for our patient population. I alluded to the PROCEED trial, which is trying to evaluate the same question in a prospective manner, and we're hoping that will read out sometime next year. But those are probably the best data that we're going to have in terms of the benefit of IVIG replacement. To my knowledge, there's not as much data in terms of efficacy of infusion versus subcutaneous administration. There is some changes in terms of how well it's distributed in the body and how quickly it gets distributed throughout the body, and therefore probably how quickly it gets clear from the body, depending on which route the antibodies get administered. But I'm not sure that there is any clinical difference